A pleasant day to everyone. Thank you for joining us in our virtual postgraduate course. I am Dr. Anne Christine Quero Tagawa, and for this afternoon session, we will be discussing the various transfusion reactions. Our objectives for this session are to review the blood transfusion reactions and their pathophysiologic mechanisms, and to review the approach to management of transfusion reactions. Blood transfusion is done for many reasons, including surgery, injury, disease, and bleeding disorders. And as such, transfusions can be life-saving for patients with severe anemia, thrombocytopenia, or deficiency of plasma components. In general, transfusions are safe. However, as with any intervention, it is not entirely free of risks and hazards. Allogeneic blood cells and plasma proteins are foreign substances that can elicit an immune response in the recipient, and plasma contains antibodies and other immune mediators that can react with recipient cells. As a result, blood transfusion can be complicated by various reactions, broadly coined as adverse transfusion reactions. Risks of blood transfusion may range from minor complications to life-threatening fatal conditions. The precise risk of an adverse reaction during blood transfusion is difficult to estimate. Symptoms may be nonspecific, such as urticaria, fever, or chills, and several reactions are often attributed to patients' underlying illness, while some transfusion reactions occur in anesthetized patients in whom reactions are harder to recognize since they are unable to verbalize any symptoms that they are feeling. The pathophysiology of a transfusion reaction varies. Transfusion reactions may either be acute or delayed, immune mediated or non immune mediated, and non infectious or infectious in nature. We have here a retrospective study by Pai conducted in the blood bank of a tertiary care center in Bangalore. The data was collected over a period of 4 years and 3 months from October 2015 up to December 2019. A total of 6,910 units of blood and its components were issued to patients during the study period. Out of them, 35 patients developed adverse transfusion reactions, accounting for an incidence of 0.5%. All the transfusion reactions in the present study were acute reactions. There were no delayed reactions recorded, and it was also noted that adverse transfusion reactions were more common with transfusion of packed RBCs as compared to that of platelets. There were no reactions observed with the transfusion of whole blood or that of fresh frozen plasma. In this prospective study by Krishnamurthy et al., this included all the ATRs reported to a hospital blood bank over a period of 42 months. Among 19,800 transfusions, 189 transfusion reactions were encountered, accounting for an incidence of 0.95%. Again, all cases in the study were of acute transfusion reactions. Acute transfusion reactions occur during or within 24 hours of blood transfusion. The most common signs and symptoms include fever, chills, urticaria, and itching. Some symptoms may resolve with little or no treatment. However, respiratory distress, high fever, hypotension, and hemoglobinuria may indicate a more serious reaction. Allergic transfusion reactions are common and are most often associated with itching and hives. These reactions can be due to both recipient predisposition to allergic reactions and donor factors. It is immune mediated. The most common cause is an antigen-antibody interaction that occurs between the patient and the product. Commonly implicated antigens include a number of donor serum proteins. An allergic transfusion reaction is not a contraindication to continuing the transfusion as long as it is clear that there are no other allergic symptoms. Antihistamines can be given for symptom relief but are not indicated prophylactically. If no other signs of allergic reaction develop, such as angioedema, wheezing and respiratory distress or hypotension, then blood transfusion may be resumed. The next acute transfusion reactions are anaphylactic reactions. They are severe allergic reactions and typically result from sudden and massive systemic release of mediators such as histamine and tryptase by mast cells and basophils in response to an IgE mediated or IgG mediated immune reaction. Anaphylactic reactions may occur in IgA deficient individuals who produce anti IgA antibodies that react with IgA in the transfused products, or patients who have allergies to another constituent in the transfused product. This is a potentially life threatening reaction, but it is relatively rare. Anaphylactic transfusion reactions are of rapid onset, typically occurring within a few seconds to a few minutes following initiation of a transfusion. The patient may experience shock, hypotension, angioedema, respiratory distress, or wheezing. These may or may not be preceded or accompanied by symptoms commonly described in allergic transfusion reactions, including pruritus, urticaria, and flushing. Transfusion should immediately be stopped and intramuscular epinephrine be administered. Intravenous fluid resuscitation should be started among hypotensive patients, and some may also require vasopressors. Airway should be maintained and oxygen should be given when needed. For pruritus or angioedema, an antihistamine may be administered. The next transfusion reaction are hypotensive transfusion reactions. They are characterized by a drop in blood pressure without other causes of hypotension. Systolic blood pressure decreases by 30 mm mercury or more and may fall to less than 80 mm mercury within minutes of onset of transfusion and returns to baseline once the transfusion is stopped. Other types of transfusion reactions associated with hypotension, such as acute hemolytic reaction, transfusion related acute lung injury, sepsis, and anaphylaxis or other underlying diseases, must be excluded before a diagnosis of primary hypotensive reaction is made. The mechanism is thought to involve vasoactive kinins such as bradykinin. The reactions are rapidly reversible and generally do not require specific treatment or prevention, except for possible avoidance of ACE inhibitors prior to planned transfusion or apheresis. Hypotensive reactions are rare transfusion reactions. Another acute transfusion reaction is febrile non-hemolytic transfusion reaction. They are characterized by fever, usually accompanied by chills in the absence of other systemic symptoms. Clinical manifestations of febrile non-hemolytic transfusion reaction occur within 1 to 6 hours after initiation of a transfusion and within 4 hours of transfusion termination. They are among the most common cause of all transfusion reactions, occurring in approximately 1% of all transfusions. Because the development of other symptoms is not known at the time of the initial fever, febrile non-hemolytic transfusion reaction is a diagnosis of exclusion. The possibility of other febrile transfusion reactions must be eliminated, including acute hemolytic transfusion reaction, sepsis, and CHALI. The most common cause of febrile non-hemolytic transfusion reaction is release of cytokines from white blood cells in a product that has not been leukoreduced. If there is just fever and no other significant reaction is suspected, antipyretics like paracetamol may be given. Other medications like meperidine may be administered for severe chills or rigors. The transfusion can usually be continued, but patients should be monitored closely. From non-hemolytic transfusion reaction, we now move to acute hemolytic transfusion reaction. It is caused by acute hemolysis of transfused red blood cells. Hemolysis can either be intravascular, causing release of free hemoglobin into the circulation, or extravascular, resulting in removal of red blood cells by the reticuloendothelial system. This may be due to ABO incompatibility or caused by a reaction to alleles in other RBC antigen systems. Isohemagglutinin can activate the complement and coagulation systems. C3A and C5A can activate white blood cells to release inflammatory cytokines. ABO incompatible transfusion reactions are often the result of clerical error, leading to transfusion of a product not intended for the recipient. It is rare but is a life-threatening reaction, and rapid intravascular hemolysis can lead to acute kidney injury, disseminated intravascular coagulation, and hemodynamic collapse. The classic acute hemolytic transfusion reaction is a medical emergency requiring immediate intervention. Typical symptoms and findings include fever, chills, back or chest pain, and pink or red serum, plasma, or urine, although the full classic triad of fever, flank pain, and red urine is rarely seen. It is critical to immediately stop the transfusion and communicate with the transfusion service. This allows for appropriate record checking, which may prevent administration of a wrongly labeled unit to another patient. Treatment involves aggressive hydration and diuresis, and patients should also be tested for DIC, and additional tests for blood compatibility should be done. The next transfusion reaction is relatively rare. Transfusion-associated sepsis or transfusion-related sepsis is caused by transfusion of a product that contains a microorganism. Unlike sepsis from an underlying localized infection, transfusion-associated sepsis may involve a large intravenous inoculum, which in the case of gram-negative organisms could include an infusion of endotoxin, leading to high fever. Initial findings may include fever, chills, and hypotension. Transfusion should be stopped, and treatment includes broad-spectrum antibiotics and hemodynamic support. Gram stains and cultures on the remaining blood product and the patient should be performed. Intravenous broad-spectrum antibiotic therapy should be administered based on the severity of clinical symptoms or suspicion of a septic transfusion reaction. Antibiotics may be adjusted based on the results of the gram stain or culture, but should not be withheld while awaiting these results. This next transfusion reaction is a life-threatening form of acute lung injury. Transfusion-related acute lung injury occurs at a rate of approximately 0.04 to 0.1% of transfused patients, or in approximately 1 in 5,000 transfused blood components. It is the number one cause of transfusion-related mortalities. Chally occurs when recipient neutrophils are activated by the transfused product in an appropriately primed pulmonary vasculature, and this is due to the transfused product having either anti-HLA or anti-neutrophil antibodies. The generally accepted theory for Chally pathogenesis is that it occurs via a two-hit mechanism. The first hit involves neutrophil sequestration and priming in the lung microvasculature due to recipient factors such as endothelial injury. Priming refers to shifting of neutrophils to a state where they will respond to an otherwise weak signal. The second hit is activation of recipient neutrophils by a factor in the blood product. Activation is associated with the release from neutrophils of cytokines, reactive oxygen species, oxidases, and proteases that damage the pulmonary capillary endothelium. This damage causes inflammatory pulmonary edema. Chally should be considered whenever a patient develops hypoxemic respiratory insufficiency during or shortly after transfusion of any blood product. Chally is a clinical diagnosis made using the criteria outlined by the NHLBI's Working Group on Chally as well as the Canadian Consensus Conference on Chally. These criteria require the presence of new acute respiratory distress syndrome occurring during or within 6 hours after blood product administration, documented by hypoxemia and abnormal chest imaging. Hypoxemia is documented when oxygen saturation is less than or equal to 90% on room air or the PF ratio is less than 300 millimeters mercury. although other signs of hypoxia can also satisfy this criterion. Chest imaging must demonstrate bilateral pulmonary infiltrates. Presenting findings in CHALI include hypoxemia, fever, hypotension, and cyanosis. Other reports have also noted tachypnea, tachycardia, and elevated peak and plateau airway pressures in intubated patients. An acute transient drop in the peripheral neutrophil count has also been reported. Therapy for CHALI is largely supportive and may include intubation and mechanical ventilation. Among patients with hypotension, fluid resuscitation and vasopressor should be given. A subsequent evaluation is directed at identifying the donor so that individual does not continue to donate and potentially cause CHALI in other patients. The efficacy of corticosteroids has not been tested in prospective clinical studies, and the limited anecdotal evidence for it is unconvincing. Thus, it is not recommended to use corticosteroids when CHALI is suspected. Another life-threatening transfusion reaction is transfusion-associated circulatory overload. TACO is a common transfusion reaction in which pulmonary edema develops primarily due to volume excess. TACO typically occurs in patients who receive a large volume of a transfused product over a short period of time, especially those with underlying cardiovascular or renal disease. The possibility of TACO should be considered in any patient who has new or worsening respiratory distress during or within 12 hours of completing a transfusion. Findings on examination may include hypoxia, hypertension, tachycardia, a wide pulse pressure, and jugular venous distension. The cardiac examination may show an S3 heart sound, and the lung examination often reveals rouse or wheezing. Oxygenation status should be assessed using pulse oximetry or arterial blood gas analysis. Chest radiography should be performed for all severe reactions associated with respiratory or hemodynamic compromise. Typical findings on chest radiography and TACO include pulmonary edema and, in some cases, cardiomegaly. Treatment of TACO is similar to treatment of cardiogenic pulmonary edema from other causes. Once the diagnosis is strongly suspected, the transfusion should be stopped. The major interventions include fluid mobilization through diuretics, supplementary oxygenation, and assisted ventilation if indicated. Placing the patient in a sitting position can also be helpful. CHALI is often considered as a differential diagnosis to TACO. A key distinguishing feature between CHALI and TACO is that TACO symptoms improve with diuresis. Other helpful features to distinguish between the two are presented in this table. To reiterate, acute transfusion reactions occur during or within 24 hours of blood transfusion. This figure is a summary of the various acute transfusion reactions based on their presenting symptoms. Delayed transfusion reactions, on the other hand, are those that occur more than 24 hours after transfusion. In general, immediate transfusion reactions are more dangerous than delayed transfusion reactions. Delayed hemolytic transfusion reactions most commonly present 1 to 2 weeks after transfusion of red blood cells, although the interval can range from 24 hours to 28 days. The CDC in the United States have defined criteria for a delayed hemolytic transfusion reaction that require a positive DAT, identification of red blood cell antibody in serum or elevate, and laboratory findings such as inappropriate hemoglobin increment, spherocytes on PBS, or findings of hemolysis. Delayed serologic transfusion reactions are identical to DHTRs except that the patients are asymptomatic and lack evidence of hemolysis. CDC defines a DSTR as absence of clinical signs of hemolysis and detection of a new clinically significant antibody by either a positive DAT or a positive antibody screen on subsequent type and screen sample testing. DHTRs and DSTRs are most commonly due to an anamnestic response to a foreign RBC antigen to which the recipient was previously exposed. A delayed hemolytic transfusion reaction may less commonly present with intravascular hemolysis and associated findings similar in quality but often less severe in degree compared with intravascular hemolysis during an acute hemolytic transfusion reaction. For individuals with a DHTR, the hemoglobin level should be monitored until it is clear that hemolysis has ended. The frequency of monitoring is determined by the severity of hemolysis. If there is ongoing hemolysis, it would be prudent to consider giving a glucocorticoid, IVIG, or rituximab. For both DHTR and DSTR, it is critical to avoid future transfusions containing the implicated RBC antigen. It is therefore important to perform the evaluation and document the alloantibody and inform the patient and caregivers of the importance of avoiding the antigen in future transfusions. The next delayed transfusion reaction is transfusion-associated graft versus host disease. It is rare and usually fatal complication of blood transfusion in which lymphocytes from the transfused blood component attack the recipient's tissues. This typically develops between 4 to 30 days after a transfusion. This may occur when transfused lymphocytes are viable and one of the following is present. Number one, the recipient is immunosuppressed, or number two, there is partial HLA matching between the transfused product and the recipient. Viable T lymphocytes from the transfused blood component are able to engraft, proliferate, and attack HLA expressing tissues in the host. Normally, lymphocytes present in the transfused component would be destroyed by recipient's immune system before they can mount an immune response. In transfusion-associated GVHD, the recipient's immune system either does not recognize the donor lymphocytes as foreign or is unable to mount an effective immune destruction. The attack of recipient tissues affects all tissues that express HLA class II. These include hematopoietic stem cells, intestinal epithelium, and skin. As a result, the recipient develops profound pancytopenia from bone marrow aplasia, as well as gastrointestinal effects and skin changes. There is no effective treatment for transfusion-associated GVHD other than hematopoietic stem cell transplantation. Immunosuppression could mitigate the activity of the T lymphocytes, and the most commonly used agents include glucocorticoids, cyclosporin, IVIG, ATG, or ALG. However, numbers in studies were too small to detect a significant association of any treatment with improved outcomes. The last transfusion reaction that we will be discussing is post-transfusion purpura. It is an extremely rare transfusion reaction. Data are limited, but the incidence has been estimated to be approximately 1 in every 50,000 to 100,000 transfusions. PTP occurs primarily in individuals sensitized to platelet antigens by exposure during pregnancy or transfusion. PTP can be thought of as a delayed transfusion reaction involving platelets in which an anamnestic response to a previously encountered foreign platelet antigen leads to an increase in production of antiplatelet antibodies by the recipient. The antigen most commonly implicated is the human platelet antigen 1A. These antibodies cause destruction of both transfused platelets as well as bystander destruction of the patient's own platelets, leading to thrombocytopenia. Patients with PTP can present with severe thrombocytopenia sufficient to cause purpura, petechiae, and clinically significant bleeding. The onset is approximately 5 to 10 days following transfusion, and the thrombocytopenia often lasts for days to weeks. The preferred therapy for PTP is IVIG, and high-dose glucocorticoids have been useful in some patients, as well as exchange transfusion. In summary, we have discussed the following transfusion reactions. They may be grouped according to the type, whether acute or delayed, or also whether they are immune mediated or non immune mediated. For the key points of this discussion, blood transfusion, although life-saving, can be complicated by various reactions. This may range from minor complications to life-threatening fatal conditions. When a patient is experiencing symptoms or signs consistent with a transfusion reaction, transfusion must be stopped. Evaluation must be done promptly, and treatment must be administered expeditiously to minimize the impact of the reaction. And of course, prevention is always better than cure. We must always practice judicious use of blood components by assessing need for transfusion, using only the appropriate components, and avoiding unnecessary transfusions. These are my references, and thank you for your kind attention.